Good morning, everyone. This hearing is called to order. I recognize the President of Quorum and committee members. This is a public hearing of the Committee of the Whole regarding bills number 170195, 170196, 170197, and resolution number 170213. Mr. Stitt, please read the titles of the bills and resolution.
Bill number 170195, an ordinance to adopt a capital program for the 6 fiscal years 2018 through 2023 inclusive. Bill number 170196, an ordinance to adopt a fiscal 2018 capital budget. Bill number 170197, an ordinance adopting the operating budget for fiscal year 2018. Resolution number 170213, resolution providing for the approval by the Council of the City of Philadelphia of a revised 5-year financial plan for the City of Philadelphia covering fiscal years 2018 through 2022 and incorporating proposed changes with respect to fiscal year 2017, which is to be submitted by the Mayor to the Pennsylvania Intergovernmental Cooperation Authority, the Authority, pursuant to the Intergovernmental Cooperation Agreement, authorized by an ordinance of this Council, approved by the Mayor on January 3, 1992, Bill number 1563-A, by and between the City and the Authority.
Thank you, Mr. Stitt. Today we continue the public hearing of the Committee of the Whole to consider the bills read by the clerk that constitute proposed operating and capital spending measures for fiscal 2018, a capital program, and a forward-looking capital plan for fiscal 2018 through fiscal 2023. Today, we will hear testimony from the following city departments: Behavioral Health, Public Health, Department of Human Services, Office of Homeless Services, Mayor's Office of Community Empowerment and Opportunity. Mr. Stitt, the first person to testify is?
Roland Lamb.
Thank you.
Good morning, President Clark and members of City Council. I am Roland Lamb, the Deputy Commissioner. Joining me today is Sandy Vasco, Director of the Office of Behavioral Health. I am pleased to provide testimony on the Department of Behavioral Health and Intellectual Disability Services Fiscal Year 2018 operating budget. The mission of the department is to educate, strengthen, and serve individuals and communities so that all Philadelphians can thrive. We envision a Philadelphia where every individual can achieve health, well-being, and self-determination. The proposed fiscal year 2018 operating budget totals $285,236,248, an increase of $117,012,397 over fiscal year 2017 estimated obligation levels. This increase is primarily in the Health Choices Behavioral Health Fund and is attributed to an annualized enrollment due to managed care expansion. The FY2018 operating budget request of $1.6 billion includes $14,218,574 in the general fund, $271,017,674 in the grants revenue fund, and $1.3 billion in the Health Choices Behavioral Health Fund. The department is requesting 273 budgeted positions for FY2018, 16 in the general fund, and 257 in the grants revenue fund. Of the $1.6 billion proposed, $68.6 million, or 4.4%, is for intellectual disability and early intervention services, and $1.5 billion, or 95.6%, is for behavioral health services. The proposed FY2018 budget includes $25,873,569 in Class 100, $1,557,394,598 in Class 200, $202,500 in Class 300, $82,500 in Class 400, and $1,683,081 in Class 800. 82% or $1.3 billion of the department's budget is allocated via Health Choices Pennsylvania's Medicaid appropriation system, which is overseen by Community Behavioral Health, who provides services to the 650,000 Philadelphians on Medicaid. The Affordable Care Act, or ACA, expansion enabled 220,000 adults, or 1 out of every 6 Philadelphians, to gain coverage. This expansion continues to prove to be vital in enabling formerly homeless individuals now housed through permanent supportive housing and afforded access to necessary behavioral health supports to become active and contributing members of their communities. The department has witnessed that behavioral health supports provide a cost-saving mechanism enabling us to reinvest valuable dollars back into proven effective services. A one-year cohort analysis of those utilizing core services offered via permanent supported housing demonstrated that utilization service costs decreased by 29% solely due to the fact that individuals were readily accessing less intensive, more appropriate levels of care. In addition, through the current payment structure and funds that CBH receives through Medicaid compensable services, the department is able to provide a wide array of behavioral health supports, including assertive community treatment, teams, drug and alcohol case management, mental health and co-occurring case management, certified peer specialist services, and mobile psychiatric services. In addition, under the ACA, Medicaid compensable services were expanded, enabling the department to reallocate safety net funds for population health initiatives such as the early intervention programs for adults and adolescents who are at risk of developing substance use disorders. As a department, we have been able to utilize funds in innovative, creative, and proven effective ways to ensure that all are receiving the appropriate level of care as they work towards their recovery. The department is responsible for serving children, youth, adults, and families in Philadelphia with behavioral health challenges and/or developmental and intellectual disabilities. Less than 1%, or $14.2 million, of the overall budget allocated to the department comes from the city of Philadelphia, and as demonstrated in a recent economic impact study conducted by Drexel University and the Scattergood Foundation, the work of the department continuously acts as a stimulus to the city, producing a nearly $4 billion impact to the local economy. In FY2018, the department will continue to focus on fundamentally transforming the local network of care, as well as creating and implementing programs that align with a population health approach. The following includes forthcoming plans for FY2018, as well as the successes from FY2017 that will continue through the new fiscal year. I will highlight the following 4 areas. Number 1, addressing the opioid epidemic. Number 2, trauma-informed care. 3, child and family services. And 4, evidence-based practices. 1, addressing the opioid epidemic. Through FY2017 and continuing in FY2018, the department will continue to invest time, energy, and resources in the opioid epidemic. Within the Community Behavioral Health Network alone, 57 providers offer substance abuse treatment options at 157 sites across the city. Community Behavioral Health continues to ensure that the most effective treatment is available for those with substance use disorders. When adequately administered, medication-assisted treatment is known to reduce illicit opioid use and improve treatment retention among those with substance use disorders. Research suggests that medication-assisted treatment is cost-effective. For every dollar invested into maintenance therapy, treatment options result in a savings of $1.80 in future treatment costs. Given the proven effectiveness of medication-assisted treatment as a treatment option, Community Behavioral Health has added an additional 500 methadone treatment slots, 900 buprenorphine slots, and increased the number of outpatient and residential sites that offer Vivitrol, 14 and 4 respectively. The department continues in collaboration with Prevention Point Philadelphia, the only sanctioned syringe exchange program in the region, to provide much-needed behavioral health services and referrals alongside their cornerstone needle exchange program. The Coordinated Response to Addiction by Facilitating Treatment, or the CRAFT project, is a departmental program that collaborates with Prevention Point and seeks to increase linkages to behavioral health care among some of the city's most vulnerable residents, and seeks to address access problems faced by the target population in efforts to reduce the rate of overdose fatalities in the city. The department continues to successfully move towards a population health approach by which we seek to serve the whole individual and strive to limit the development of disease and infirmities by instituting preventative measures that enable overall wellness. The department has partnered with the City of Philadelphia's Department of Public Health to release the opioid prescribing guidelines, which have been distributed to all physicians in the city and provide simple, practical guidelines with the goal of limiting the unnecessary prescribing of opioids. Similarly, prescribing guidelines have been created for benzodiazepines, as these substances, particularly when combined with opioids, contribute to a large portion of overdose deaths. We also ensure that a large portion of our employees and providers are equipped to respond in case of an opiate-related overdose. To date, the department has trained more than 25% of staff members, 236 to date, and 236 individuals, in administering naloxone or Narcan, the life-saving overdose prevention medication, and trainings will continue on a quarterly basis. The department continues to work with physical health managed care organizations as well as the Commonwealth of Pennsylvania to further develop the opioid use disorder centers of excellence. The department is also working to develop a 24/7 walk-in center where individuals can receive immediate stabilization support while remaining in an outpatient setting. Additional FY8 plans include the creation of a substance use early intervention program that will provide services for adults who are currently using substances and do not meet criteria for substance abuse or dependency, but are at risk for developing a substance use disorder. 2, trauma-informed care. Philadelphia has emerged as a national leader in the public promotion of behavioral health via mental health first aid. Mental health first aid, is a groundbreaking early intervention public education initiative that teaches community members how to identify, understand, and respond to individuals experiencing behavioral health challenges and crises. Training has been made available to the public, faith communities, the Philadelphia Police and Fire Departments, the School District of Philadelphia, and many other organizations. The Network of Neighbors Responding to Violence seeks to provide trauma support to communities in the immediate aftermath of violence, most often gun violence. Network members are trained in post-traumatic stress management to become acute trauma responders who tap into a community's social connections and conduct group sessions to foster healthy coping mechanisms. Over the next 5 years, the department will expand the network by training 400 additional trauma responders. Healing Hurt People is a hospital and community-based intervention program based in medical emergency departments that provides assistance to individuals and families victimized by physical violence. Youth and young adults who present in emergency rooms with violence-precipitated injuries are screened to assess levels of need for behavioral health and other follow-up support services. In 2016, the University of Pennsylvania's Presbyterian Hospital was added as a service area. Healing Hurt People is currently functioning in 5 hospitals throughout the city. 3, children and family initiatives. The department continues to implement school-based services through long-standing, highly collaborative partnerships with the School District of Philadelphia. This relationship affords access to a continuum of behavioral health programs for school-age youth and allows youth and families to access services. Prevention, early intervention, assessment, and treatment services are
Mr.
currently...
Lamb, you don't have to read all of the testimony. If you can, I should have told you earlier, just kind of summarize it, but we got like a lot of questions. Okay. So you don't have to read it all.
Then I will move towards my conclusions then.
Thank you.
In closing, we appreciate the ongoing support of the council and the ongoing efforts to highlight behavioral health as well as the intellectual disabilities. We look forward to working with council and other stakeholders to advocate for resources to support our most vulnerable citizens. As was done in the past, I personally invite any and all council members and their staff to partake in the mental health first aid training or for the overdose rescue training. My staff and I welcome the opportunity to meet with council members at your convenience to engage in further discussions regarding content I presented before you today. At this time, I will gladly answer questions council may have.
Thank you very much for your testimony. I just have a couple of questions before I turn it over to my colleagues. In your 5-year plan, you highlighted expanding housing options by 300 units. Specifically, how are you going to do that? Existing homes, new units? How do you do that? By expanding the,
Well, we've used and leveraged our dollars to leverage slots with the Philadelphia Housing Authority.
Okay.
We're looking to create more in terms of available existing housing through those vouchers that are available. If we're able to do that, then I think we can expand housing units. The other thing is that we have collaborated with Project Home as well as Housing First to create units as well within the city. And in some cases, they've actually been new units that have been created through those organizations.
okay, so you're using your existing support for leveraging with a number of other organizations.
Right. Primarily, most of the dollars that we receive from the city are dollars that we use in order to provide funding, collateral funding for housing that's available in our system.
Okay. All right. 8th and Girard. Have your department been involved with that in any way, shape, or form? I know the answer, but I got to ask.
We've been living with North Philadelphia Health Systems at 8th and Girard. From the time, even before they were required to close the hospital at 15th and Girard and moved everything down to 8th and Girard, we have been a funder of services there and quite involved in terms of collaborating with the program at 8th and Girard, North Philadelphia Health Systems. We have been engaged with them through their declaration of bankruptcy in January. We continue to provide, supportive services to pay for services there, and we are working with them as well as the courts around their bankruptcy and making sure that we can, as much as possible, keep services from being lost in that area of the city.
And we have a looming deadline, I believe.
Well, we don't have the deadline.
They have a deadline.
They have a deadline that I think is we're working up through the end of June.
And then if they're not successful,
Then
what
the
happens?
issue for us is that we have put into place contingencies that we are looking to try to build right now with either additional providers, in the area, the surrounding area, to keep services in the area.
How many people are there that are being treated?
Oh my goodness! I think that we have approximately, I think 600 people. Yeah, on an annual basis, around 3,500. I think at any given time we may have about 600 people there in the facilities.
So what's the likelihood of us being able to find alternative options
Well,
or
we think
alternative
that
locations for treatment?
there is a likelihood. The question is whether or not we can keep all those services together in a comprehensive delivery system. That's what we're very much concerned about. The issue for us is probably going to be, can we now create the same compendium of services, maybe managed by different sources across that area of North Philadelphia?
All of the people from North Philly?
Not all from North Philly, but I would say a good section of people, at least 50% of the people are from North Philadelphia.
What percent?
I think it's at least 50% from North Philadelphia.
So is there a reason why we would need to service those people only in North Philadelphia?
Well, when you consider the services that are offered at North Philadelphia Health Systems, we would want to keep those services there. Now, maybe all.
I'm assuming that option is no longer available.
Well, the option is no longer available. Then we are going to have to look at moving people to other areas of the city.
Yeah, that's my question. It's like, are you limiting your locations, potential locations? And we hope this doesn't happen, obviously, to just North Philadelphia, given the fact that all of the people that are being serviced there are not necessarily from North Philly. Because I would think that you're limiting your locations and your options.
In fact, we're looking at as far north as northeast Philadelphia, where there's capacity at the program on State Road. At a program on State Road, we're also looking at programs throughout the city of Philadelphia where there's a possibility that we have, options. But right now, the idea is that, where are the most needed services needed the most?
Right.
And I think that's where we're concerned about at this point.
Okay. Community schools. One of the challenges that we found in our analysis of the various community school models was the behavioral health of young people in some of these schools that has limited their ability to learn. frankly speaking. You come in class, you have these different challenges from a mental health perspective, and not to mention physical health, that has impeded the ability for us to teach that child in a way that that child should be taught. Over the last couple of years, we talked about ways of funding programs, and as I'm looking at the budget of the whole health aspect of the city's government, is bigger than a whole lot of cities. And one of the things that we believe that you can essentially use money that we're currently spending in the programs that you administer in community schools or in other opportunities. Have you had conversations with the people that run the community schools about providing services in some of these schools for children?
Yeah, we just had a meeting with the community schools around providing services and around the initial formulation of plans to support community schools with behavioral health services. Okay. They are very much in the beginning stages, but I think that it's a start. It's a very good start in terms of moving towards coming up with a plan for community schools.
So, in terms of your meetings, are they driving this discussion? I mean, I'm just trying to get a sense. In all due respect to my good friends at community schools, that's not really their profession. The behavioral health aspects of what we hope to do. You guys are the professionals, and from my perspective, I would like to see the conversation being driven by you all in terms of what services should be provided in those schools, in the locations. Is that the way the conversation is happening, or is it that they're trying to figure out what they're going to do? As an example, in Gideon, just put it out there, which is one of the community schools that we selected, we actually had the principal do some work leading up to the announcement, clear some space, a lot of space in there for the ability to deliver services, both mental and physical. But we're not anywhere beyond just that conversation, and we're at a point now where they want to know who's going to come in and actually be the provider. But there's been no discussion about possibly having you all come in and providing some of the resources, i.e. money, to get that done.
Well, we've had the initial conversation, and I think that there is an intention for us to sit down and go over the services that we are able to provide on the basis in terms of behavioral health care with the school. I think the idea is that we've begun that collaborative process. Okay. We may have the information in the background with respects to the behavioral health services, but the school is providing an environment, as you said earlier, in which those services have to thrive.
Right.
And so what we're looking to do now is come together, bring our thoughts with their thoughts, and come up with a program that meets, I guess, the best opportunity for us to be successful in this initiative.
Okay. Can you provide, and it can be offline, the person from your shop who's responsible for the interaction with community schools? 'Cause I'm getting a lot of heat from that principal. Okay. Because she cleared the space and nothing's happening in there, and bottom line, I got to deliver something. Right. So if you can just offline give my staff or my office the name and the number of the person, that will be very helpful.
Right.
Thank you. Chair recognizes Councilman Jones.
Thank you, Mr. President. Thank you, Doctor. And I want to thank you publicly for a couple of things. There is nothing that an elected official can do, well, I guess if we got training, to prepare you for a mother that comes in your office and says, please get my son some help, because if you don't, he's going to get in deeper trouble. And to not be prepared and to be able to rely on you and your staff to take care of that was a life preserver, not only for me, but for her and her family. And that didn't happen just once. It happened several times, where either through the use of marijuana through K2 that was mind altering caused the child to act out in destructive ways. Mm-hmm. So we appreciate that, and I want to continue to work with you on that. A couple of things up. I'm going to leave some of the more challenging questioning about aspects of service delivery like Wordsworth to some others, because I know that's where they want to go. I want to focus my questioning last year you talked about your goals to increase diversion services from prisons for people due to mental health concerns. How much of your resources is dedicated to that, and what was the result?
Well, we're continuing to dedicate significant resources. As you know, we have been collaborating with the state, who has been under a lawsuit regarding people who are in our state hospitals and who are also incarcerated with mental health disorders. We have been looking to expand our ability to provide services to that population and step them out of those programs. In fact, one of the issues regarding North Philadelphia Health Systems is the fact that we have a significant, number of folks that we've actually diverted to services there. We're also looking to build services elsewhere throughout the system, and we've dedicated significant resources to that end. I think that we've done a great job up until running into some roadblocks as far as expanding the facilities or the ability of the facilities to take people. But I think that we're moving in a very collaborative way with the courts and the district attorney's office and the public defender's office to move people out of our system.
So numbers, Councilman Dom has trained us to focus on the numbers. How much resources, how many beds that would have been on State Road that are now in mental health hospitals, and what is at 132 a day, what is the savings or differential in that? And if you don't have that, please provide it to us during the course of this testimony. Now, question, so that answer drives me to say, is it enough? Do you need more? Is there other ways that we can raise that money by way of maybe an excise tax for marijuana, whatever those things? What revenue would you need to increase that? Because if you are a part of the reason why we've reduced our census population and people are getting more help than they would have, those are good outcomes. So I need the number of how many beds, how many patients, how much savings.
Okay. Can we get those numbers to you?
Sure.
Okay. All right.
So in that regard, you answered it kind of. You've been working with the Justice Group, CJAB, and others to be a part of any diversionary programs, any alternatives to incarcerating people. You are a part of that planning. All right. So I need to see, the problem we have sometimes is quantifying how, so we want to all do good, but we also have to know how much good costs. And if we can make that math make sense, we can make and do more good. So that is an important aspect. You talked about it in last year's testimony, and I want to see what those measurables are now.
But we can say this, that we have expanded the community residential treatment beds by 60. We also have, built a forensic support team that has actually been going out and supporting the folks that have left the incarceration and moved into the community as ongoing supports for that team. We are also, looking at the fact that we have a MacArthur Foundation, a justice grant that we have been providing for planning and implementation of new services throughout the city, and we've increased the amount of forensic screening and assessment.
So in less than medical technical terms, if an individual goes into someone's court and they need mental health treatment versus incarceration, we are building the infrastructure to be able to accommodate that?
Yes.
Thank you, Mr. President.
Thank you, Councilman. Chair recognizes Councilman Greenlee.
Thank you, Mr. President. Good morning.
Good morning,
just,
sir.
Quickly, as you talk about addressing the opioid epidemic, and you talk about your collaboration with Prevention Point.
Yes.
And we know Prevention Point with the needle exchange program, which I think is necessary, but I know sometimes can be controversial. But could you just discuss briefly some of the other, as you put it, collaboration with, on services that you work with?
When you consider the fact that that the syringe exchange is only a part of what they do,
Right.
and that harm reduction is really, part of the more significant things that they do in terms of tertiary screening of people who are coming in off the street for medical issues, providing shelter housing, also, a warm place to be. We have instituted a program since people are coming there, and they've exchanged over 2 million syringes a year. We have actually put people on the ground at Prevention Point as far as the coordinated response to addiction by facilitating treatment to actually provide authorizations to care on the ground. We've also provided work with and provided funding for them to put mentors in the community for single language speaking people to have access into treatment and to do outreach. So, for us, Prevention Point has become a really ground zero panacea for engaging the community and provided us, firsthand access to the community.
I think that's real important because I think people know about the needle exchange, but they may not know about all the other things that Prevention Point
I would invite everyone to at least spend a day at Prevention Point to see what's going on and see how they are actually interfacing with a population that is extremely vulnerable and extremely fragile.
Okay. All right. Thank you, sir. Thank you very much. Thank you, Mr. President.
Chair recognizes Councilman Down.
Thank you, Council President, and good morning.
Good
I
morning.
have about 5 or 6 quick questions, so the more efficient you can make the answers, the more I can get my questions in. Well, I just want to make sure I understand the lay of the land. In your department, behavioral health, the budget's about $1.6 billion.
Yes, sir.
And in DHS, the budget's about $700 million. And in public health, it's $114 million. The total of those three is $2.4 billion. And roughly in our budget for this year, the payroll of this city is between 1.5, 1.6. So this is clearly the biggest area of monies that we allocate by far. Having said that, the way I understand your budget, from the general fund, it's $14 million.
Yes, sir.
And the rest of the money is coming from the state and federal government.
Yes, sir.
So I do want to compliment you on one important detail, and that is from the city of Philadelphia, you're only asking for $86,000 more. That's good. But the other side of it, from the federal government side and state side, I'm trying to understand, in your class, I guess it's 200, really the big difference in your budget is class 200. That's where all the money is. $17 million increase. But from 2016, $1,120,000,000 to next year, $1,571,000,000 is a 40% increase. I understand it really is our money because we contribute in taxes to state funds and the federal funds. So we want to make sure it's spent correctly. What was the major reason for that? Is it a new medical Care Act, or what was the reason for that?
Well, that was, yes, when you go from 2015 through today, we saw a huge increase. Pennsylvania began to increase Medicaid, and those Medicaid expansion actually increased the impact on community behavioral health and our Medicaid, our spending dollars.
All right, and the other question, how many people does your department serve on an annual basis?
On an annual basis, about 160,000 people were responsible for over 650,000, but I think we saw about 160,000 enrolled in CBH over the course of the year.
So you have 160, but you're responsible for 660?
We're responsible, and we have the potential for responsibility of 650,000 people in terms of people who are enrolled in Medicaid in Philadelphia. But we saw, I think, actively about between 160 and 220,000 people.
Let me rephrase the question. Of the $1.6 billion, where does that money go?
Where does that money go?
How many people does that go to?
Well, primarily the 160,000 people that we saw as far as the services are concerned. Also, we have a range of support services that are provided for people in our system.
Okay.
I would tell you that, for instance, if you look at the drug and alcohol in 2016, over an annual period, we saw about community behavioral health of about over 25,000 people at a cost of approximately $10,000 a person.
So let me ask you this question, because I'm new here, basically. Have we ever had an audit, either by the controller or the state auditor general, of these departments, and not in a way to be negative, but in a way to be positive, in order to show us how we're investing our money, how we're spending the money, how do we make it better, how do we make it more productive? Have we had an outside entity look at this $2.4 billion that we invest to make sure it's done accurately?
Well, I don't know about the $2.4 billion. I do know about the money that in the Department of Behavioral Health.
Okay, the 1.6, that's your portion.
That we have audits that in fact, we just completed a triennial audit, and then we have audits that are done with the state every year. We have reporting requirements that drill down to how our dollars are spent.
But do you have an audit that says we put in $1.6 billion by department and within categories of your department, and shows where the money's going and how we can make it more productive?
I think we do. I think we do. Yes, we do.
Can we get a copy of that?
I don't see why not.
Okay, thank you. Thank you very much. Thanks for your testimony today. Thank you, Council President.
Thank you, Councilman. Chair recognizes Councilwoman Keona Sanchez.
Good morning, folks. I want to focus my first line of questioning around governance and decision-making. And you just stated that there is an independent audit that's conducted of CBH, and that's a program audit that you guys do annually?
Yes.
Who conducts that?
I think it's the state, along with the the triennials every 3 years, but there's a state. Yeah, maybe brings Joan Ernie.
Good morning. I'm Joan Ernie. I'm the CEO of Community Behavioral Health. Related to the audits for the Health Choices program alone, there is a very rigorous financial review process that the state does, and we are required to submit a financial audit on an annual basis. That includes both CBH and the city. There is also independently, which Mr. Hoffler can speak to, and Roland, a audit that the city does on the county side.
So we don't hire an independent outside. This is state auditing and internal auditing.
No, we do an outside entity that does our audit.
And who is that?
No, it's terrible. It's Deloitte, I believe.
Yes.
Yeah, it's Deloitte.
And where is that audit provided?
The audit is sent actually to the board of directors, and then it's on to the state.
Okay.
It's actually finishing up. It's required in May of this year.
Okay. I look forward to seeing the last audit
Sure.
to that. As you know, in May of 2016, I put forth a resolution to discuss an oversight cabinet for what I consider our vital safety net programs, and we've been in discussions around some of the governance and decision-making that exists within CBH. Since the CBH was founded, what was it? What year was that?
20 years ago,
20 years. Has there been any review in its entirety about its formation and its oversight?
So I'm not sure if I completely understand the question. There is a rigorous oversight process that an independent entity called IPRO. There is also Mercer, which is a national company that the state hires to do a programmatic review of
So let's
CBH.
talk a little bit about the state oversight. Do you believe that the state provides adequate oversight for all of the licenses they issue that you fund?
The state does, you mean the license of the agencies?
Of everything. We fund and contract agency based on
Correct.
state standards.
Correct.
So do you believe that the state provides adequate oversight and standards for the facilities that they license?
I do believe that they have a rigorous licensing process, that they really make every effort to assure that there is sound licensing.
Okay. Do you believe that the state has a very clear, transparent protocols around how they engage in their licensing process?
So my previous life, I worked at the state, and so was responsible for licensing on the Office of Mental Health and Substance Use side. I do believe that with any licensing process, there is always an ability to do better. When they transitioned to a different licensing strategy by combining, it was called BHSL, I think that was not as productive, and they have disbanded that. So I do believe that the licensing now, as it returns to its original intent, will be stronger.
So do you believe that we should be okay with allowing just their state licensees to determine who we contract with?
So for the Health Choices program, state licensure is not the only requirement for contracts. In 1997, there wasn't any willing provider requirement, but since that time, we have in fact done a lot more significant monitoring, both at the Health Choices side and on the city side, to do and assure that not only is the license, but also the board signs off on a credentialing status that happens routinely.
And where is all this information laid? Where is the transparency of this outside of your board of directors?
Right now, it is not displayed publicly. We do have and provide an updated 20th anniversary report. We are intending to do an annual report following that. We have, in fact, done pay for performance, and this year, pay for performance will, in fact, be a document that agencies will receive, public feedback against how they did in terms of their results against all the other agencies.
Do you not think that this, as a board of directors, and I look at city council as the board of the directors, that this information should be more transparent and public?
So I think that's pretty much of a loaded question, Councilwoman.
It's intended to be.
I understand that. I think that we have made every effort to accommodate your requests. I'm not sure whether or not you've had a chance to look at what we provided. We absolutely are open to continuing those dialogues with you about what you believe is the most important information for you to have. We currently have approximately 200 agencies in our network. And we are very open to, making anything about CBH or the department generally available to City Council.
I'll go to my second round. I just will say for the record that we have been engaged in information. This is not about my request. It's about what Councilman Dom says about a public accountability that I think has been subpar. And I must say that up to date, I'm not satisfied with the materials submitted, because this is a billion-dollar corporation, and my expectations were that we would have a better review and oversight around this information. But in my second round, I'll talk a little bit more about that. Thank you, Mr. President.
Thank you, Councilwoman. Chair recognizes Councilwoman Gimm.
Thank you very much, Council President.
You're welcome.
I want to ask a few questions and just follow up on an earlier statement that I think was made about your work particularly around schools. I think it was pretty significant to hear that 7 out of the 9 community schools prioritized emotional health as one of their key issues. I think it's an indicator not just of particular community schools' needs, but the importance of these services that you provide in schools all across the city. And my interest is in figuring out how to more effectively deliver on our school-based services. And a key piece of that is to make sure that educators in school buildings and behavioral professionals that you're supporting are actually working in hand-to-hand. We've got 18,000 school district members in particular who need to be trauma-informed. And I know one tool you have for doing that is the mental health first aid program. So it seems like the public school notebook just reported that about 1,500 district employees are trained in mental health first aid, but that's about less than 10% of all school staff. So what efforts are you putting in right now into reaching more schools with your training, and how are you coordinating that work with the district, which now has a director of trauma-informed practices?
Well, as I understand it, we've continued to outreach to the schools to provide continuous training, as we have with other city departments, including police and fire. This is going to be an ongoing process. I think we've reached 20,000, beyond 20,000 people here in Philadelphia. Around
I'm just
it.
speaking specifically about school district staff, though.
Okay, yes, and I guess my point is that we have, beyond the school district, we've had a number of other organizations that we have included as far as the training is concerned. We're looking to expand that training going into next year, but the idea is that we have been continuing to reach out to the schools to provide more training as far as mental health first aid is concerned.
If I can add, Roland, we actually provided training so that there's trainers actually in the school district central office. A number of those staff are trained themselves to ensure the sustainability. All the school police have been trained in MHFA. We have certainly offered it beyond, the school police. And we're actually partnering with Drexel College of Public Health so that we can evaluate the impact of MHFA in the school district. But it is a close collaboration with the district itself. And again, it's a train the trainer model, so you really want them to train up so they can also train.
Yeah. And so for clarity, how much money does CBH spend in school-related services?
So CBH actually spends $73 million. The
And
city
DBH?
overall, yes, CBH is 78 or 73. Overall, the department is $78 million.
Yeah. So $78 million in schools. I'm still trying to get at the aspect of how to train beyond more than 10% of school staff. So what plans are you doing to expand your training with school district staff currently?
So the training is free. We do have, again, the model is train the trainer. The school district staff themselves are trained. We have opened it up and offered it to any and all who are interested in receiving it. I think some of it is the list of things that are required for teachers and others, their availability. But certainly we're open and willing to train as many as possible.
One of the things that we're trying to understand with the complications around the district is the district does not take advantage of opportunities. I mean, it's hard to make that happen. There are a gazillion things that are going on. Teachers are, currently without a contract, they're working overtime on a whole bunch of other things. We're still down on a ton of staff. When I hear that we're open to anyone who wants to take advantage of our programs, I'm likely hearing that no one's going to take advantage of those programs. And so with $78 million going towards our schools, with a clear understanding that so many schools are prioritizing the need for emotional health services, what more concrete plan do we have to expand the training? Is there none? Are we, what can we think about, as we move on this? And in particular, I think it has a lot to do with the fact that if the department itself has seen a 40% budget increase, what does that mean for our schools? Where are we directing a lot of these resources? But if it's real open-ended, I'm thinking that that's not going to be an advantage. We're actually not, I don't know how the district is going to take advantage of that if it's left up to individual members of school communities who often feel under siege a lot, and it's not coordinated through either the principals or potentially 440. I don't necessarily think that that's the best way, but where I need a more concrete understanding, because this is a lot of opportunities that we've got and a huge investment that we're making.
So I'll go ahead and try to support some of this conversation, and we can certainly follow up. I would say that mental health first aid is only one component of school-based services that we're in conversations with the district with. So we are not only working with them around how to access MHFA, including having a dedicated team that really is school-directed, but we also are working with them around how to utilize the student assistance program more effectively, how to utilize the services that we offer more effectively, how to think about in all of our conversations with principals, how to meet the day-to-day demands that teachers and principals really have in classrooms that at times are struggling with too many kids and kids who have some significant trauma and challenges. We work very closely with the new staff that are doing the trauma work. We've really made an investment into trauma and are really aligning those activities so that both the district and CBH have a trauma strategy to try to create that culture. And we're in conversations with the community schools and the enterprise zone around how it is that we even look at something different for those schools. What would be a better response? So.
I'll come back to this on my second round. Thank you, Council President.
Thank you, Councilwoman. Chair recognizes Councilman Green.
Thank you, Council President. Good morning. Mr. Lamb, I wanted to follow up on some questions and some information from testimony regarding opioid addiction and services. I know for a number of years your office has worked with other elected officials and others to try to cite additional methadone clinics throughout the city of Philadelphia. I'm curious from the perspective that your office has taken a position regarding medical marijuana. From my work with the National League of Cities in jurisdictions that have allowed medical marijuana, opioid addiction has actually gone down because there's been an increase of using medical marijuana as opposed to opioids for treatment of issues. And so I'm curious if your office has taken any position on that perspective.
Well, by the very definition of what we do, we pretty much respond to when people are having issues with drugs like marijuana or heroin or cocaine. The medical marijuana, I think, is something that bears looking into as far as the research that's been done on it so far, both domestically and internationally. I think that we have not yet formulated an official position on that with respects to the implementation of medical marijuana because of that, because we have not seen necessarily the kind of research that's going to be supported across the board. But I think, but again, I too agree that we need to begin to take a look at where the opportunities are as far as engaging people that are challenged by opiate dependence.
Okay. Also, following some questions that both Councilman Dom and also Councilwoman Sanchez asked regarding the department. Clearly, behavioral health has probably the largest single budget amount in our city budget process, and within that, the largest amount of that goes to community behavioral health as based on the Health Choices contract. I'm sure you're aware of the recent RFP process that the state's been taking with Health Choices. I had hearings in that regard, and there is a proposed change with some of the providers in the network that will be providing their services. Has your organization or others taken any position on how to prepare for that possible change with the providers of Health Choices?
Yes, we have. I think if I understand your question correctly, we have been looking at the fact that there are changes that are coming down on the federal level. There are also changes that are occurring on the state level. And we have been looking very carefully around at our provider network with respects to, for instance, the Imd and the size of residential treatment programs. We're also very much concerned about the current status of regulations around how programs operate. So I'm answering your question with respects to the changes in the programs. The RFPs that we've put out have identified specific kinds of changes that are meant to improve the quality of care for providers.
I'm more specifically talking about some of the changes that may be occurring with some of the managed care organizations that will be receiving dollars and how that may impact residents in the city of Philadelphia if you're changing from one managed care organization to another. Some of the managed care organizations that have been providing services have been providing services to residents for a number of years. And so my concern is that when you have that type of change, especially when a large number of people that are receiving services through Health Choices, that transition could cause significant disruption and impact continuity of care.
Yes, I think that one of the things that we have had discussions about is the fact that, we're supposed to be integrating with physical health care. And those changes that you're talking about are changes that are occurring on the physical health care side. If that is the case, then we're looking at a different landscape, so to speak, for service delivery, and we're also looking at the impact that Medicare is going to also have on those services going forward. So I would just say that we are having discussions now, but we have not reached any, I guess you can say, any kind of planning going forward as far as our treatment providers are concerned.
There are, Councilman, there's current litigation, as you know, around the health plans. Currently in Philadelphia, Health Partners and Keystone have the majority of our members. We are required to have a letter of agreement. We meet with each of them on a regular basis, which we would do if there was somebody new in. Clearly, the continuity of service is an issue, and particularly in the relationships that we're building with those two predominantly, because they seem to be the biggest market share. A change to them would be, I think, pretty significant. Some of the other organizations don't have as many members, but it would still be a concern if someone had to ensure that their providers are in their network. We can navigate that.
My concern is that considering that the RFP process is in litigation regarding health choices.
Right.
The concern if there is any type of change in those providers, how are we going to educate the citizens of the city of Philadelphia that, yes, that information you receive in the mail is not just some type of random piece of marketing, that you really need to pay attention to this? Because my concern is that if there are constituents in the city, with that change, they may not be cognizant of that change, and then they go to their physician they've been going to for a number of years, and then find out that we no longer take this type of service because the managed care organization is no longer has a contract with the state. And so the state will make those changes, but how are we trying to be proactive? Now, granted, I understand the litigation process has to work out, but I think we need to be proactive in trying to find a way to communicate information, working along with the providers that are ultimately selected to make sure we get the information out so there's not confusion and yet people impacted negatively because their continuum of care has been disrupted.
Absolutely.
I agree.
Thank you, Council President. I'll have some more questions later.
Thank you, Councilman. Chair recognizes Councilman Heenan.
Thank you, Council President. In your testimony, Roland, I just wanted to ask a few questions regarding the positions that you had mentioned, that you're seeking to add 11 new positions over what was budgeted in 2017. What are these new positions, and what is there a department strategy on filling these positions, and how do they assemble the budget that we have here in our 5-year plan? Because that will be 23 additional positions because we didn't fill 12. How does that fit into, our strategy, your strategy moving forward?
Well, we're looking to be able to keep pace with the fact that we're looking to be more diversified through a population health approach. We're looking to do more services in the community and engage across our diverse, I guess you can say, the patient population more effectively. So we're doing more kinds of community work, more kinds of outreach and the like. We're looking to create as much, the same kind of diversity in our employee makeup, our workforce makeup, to be able to do that kind of outreach and be able to engage in those services. We're also looking at developing, more evidence-based practices and engaging people along those lines. Okay, we've identified, I guess these are the 23 positions with respect to human services, executive assistant, analysts, and the like, to address those services.
I want to talk for a second about the memo that was distributed April 11th to contracted halfway house providers. Mm-hmm. How many contract halfway house providers does the city have?
Right now, I think we have halfway house, I think it's about 6.
And how many of them allow medication-assisted treatment?
I don't think any of them right now allow medication-assisted treatment.
Is there a best practice that allows the commingling of patients who are receiving MAT in their treatment versus those who are not receiving any kind of medical assistance?
Well, as far as, you mean medication-assisted treatment?
Correct.
Yeah, I think that there are some best practices out there with respects to managing, looking at managing addiction that you can have, and especially now that we have the addition of buprenorphine and Vivitrol, you can have I think, an adequate, appropriate mix of folks who are taking medication as well as folks who are not necessarily on medication, much like the same way you have with people who are on psychotropic medication who are in programs and folks who are not on psychotropic medication.
So what is the effect of the relationship on the different patients?
Well, I think the impact, I think, is a positive one when you consider both buprenorphine as well as Vivitrol, because you don't necessarily have the preoccupation that people have with in terms of a drug where they have to go and get medication every day. I think that there is a positive part about engaging people from different aspects who come through different doors as far as their recovery is concerned, and that has been shown to be the case as far as generic treatment programs are concerned.
So, and we had a quick discussion prior to this hearing, and I know we're gonna catch up. So I won't be as specific as we are when we bring some of the providers together in that offline conversation. So I'm going to be general in it, because you have 6 halfway houses now that doesn't have medical assistant treatment. All right, will they in the upcoming few months be mandated to offer MAT?
No. What they're going to be mandated to do is to actually be able to provide services to those who are on MAT. What we've had is previously is a situation where folks who are on medication-assisted treatment have actually been denied by halfway houses access into treatment. We're not asking the halfway houses to provide the medication-assisted treatment. We're asking them to collaborate with the person's medication-assisted treatment provider in terms of providing services on a halfway house level.
So on the moving towards MAT and some of the non-medical assistant providers, they're going to be having to offer that, right? Or are they being
just be able to collaborate and accept the person into the halfway house services, and who is already on medication-assisted treatment.
Okay, would they wouldn't distribute?
No.
Right. So as we move forward in the next couple months, some of the longer-term providers who are that have drug-free programs, assistant programs, as they move forward, do you think it's sort of, I think, a quick transition without seeing the actual impact with commingling of the type of treatments with patients that are going to be at the facilities?
I think that right now that there shouldn't be a problem only because we're not asking those providers to actually dispense medication or to manage medication. We're just asking them to be able to provide the halfway house services to those people who are already on the medication.
Was it a choice? Was there an outreach to engage into the facilities to have a dialogue on their successful treatment and moving towards this, additional offerings?
We've been talking to providers for over a year about this transition and the fact that we could no longer, as a system, allow for someone to be discriminated against who was on medication just in terms of having access to a program. I think that's our biggest issue right now is the fact that many of these halfway house providers offer services that are very necessary to our entire population. We want to make sure that when people can step down, from a residential treatment facility into a halfway house facility, they have access to the best resources. And in this case, all we're saying to the halfway houses is you can't discriminate.
Okay, well, I guess it's, prohibited, by the ADA. But in addition to, we'll get into specifics offline. I'd love to really dive into the weeds because this is diving into families, it's diving into our communities, and, it's going to have an impact. I'm going to leave you with this question. If you could just quickly explain the IDM exclusion and what kind of effect that's going to have on the city. I know that's not a crisis situation at this point, but it is important, and it may have an effect on, with some of our providers.
Do you want me to do?
Thank you, Councilman.
Well, I'll say this. The IMD exclusion is a federal one, whereas the regulations and really falsely, drug and alcohol got included with mental health residential services. And as such, the limitation on the number of beds that can be at any one place that can be provided is about, 16, I'm sorry. So any program that's larger than that, we're not supposed to be able to fund. We think that is a hit on our system, and we think that that needs to be expanded because drug and alcohol has some very different nuances than the mental health residential treatment facilities.
So we're going to fight to extend that.
We have been fighting, and I think that we want to make sure that we can actually, one of the things that I would like to ask is City Council support in that fight. Thank you.
Thank you, Councilman. Chair recognizes Councilwoman Reynolds Brown. Wait a minute, hold on, Councilwoman, hold on one second. I'm sorry. Chair recognizes Councilwoman Bass first, and then you, Councilwoman. All right.
Thank you.
You're welcome.
Good morning.
Good morning.
How are you?
I'm struggling as always.
I just had a couple of questions. Could you talk about prison mental health?
Prison mental health is...
Services that are provided.
Well, the services are provided in prison are more extensive than drug and alcohol, but they are still limited. We have looked to work with the prisons to get people effectively out that need mental health services into treatment facilities. Prisons usually just manage the services that are going on or the needs that are going on in incarceration. And there needs to be a much more effective, step down from incarceration to the community in terms of mental health services.
And the reason I ask that is because when I look at your list of priorities, I don't see that it is anywhere on the list. Not that it's, something that you're not paying attention to at all, but just when you look at the number of folks in Philadelphia who are going through that system, and when we talk about recidivism, we have to talk about mental health and that connection.
You're right.
And I just would like to see a much more robust connection between behavioral health and the prison mental health services that may be provided, because some of that recidivism we might be able to curtail if we get in front of it, recognize it, and are actively working to treat it. It feels as if it's a much more passive response. And that's what I guess I'm asking you to address.
Well, I apologize that we tried to use, I guess you can say, the four most active areas that we were involved in for fiscal year 18. We have since last year, and we're continuing to be heavily involved in terms of managing and developing more services for people coming out of incarceration. We've had, a number of initiatives, both in terms of the lawsuit against the state, as well as initiatives that we've been working out with the District Attorney's Office and the Public Defender's Office in terms of accessing care. And by the way, those services have been ongoing for a number of years. We have actually begun to meetings with the prisons around also doing more in terms of assessments behind the walls, so we can more clearly identify what the needs are of people coming out. But again, it was not our intention to give short shrift, to mental health in the prisons, but merely to just highlight what we're looking forward to as far as the 4 major areas going into next year.
Okay, all right. Well, if we could continue to work on that, and
Yes.
I'm sure we'll be meeting throughout the year beyond budget season to have some further conversation of that. That's something that our office has a particular interest in, and just recognizing the extreme need for mental health services in the city of Philadelphia, and just thinking about those who are in need versus those who are actually serving. Can you give us some sort of an idea of what the universe is in the city of Philadelphia? How much of the need do you think we're actually reaching?
In terms of mental health, I would...
I mean, but do you keep that sort of information? Have you gathered that sort of information? I should ask first.
We have, I guess you can say, general estimates of that information.
Okay.
Because the reality is that when you ask the question about who is in need, it's sort of like mental health. The reason why we're doing mental health first aid is that there is a whole level of population that's in our general population that is actually suffering from mental health challenges.
Absolutely.
That are not necessarily connecting to our system. And we're looking to figure out more and more ways to engage them, either through technology, through our outreach efforts, through information, and through working with other organizations to engage this population. So there is a significant population out there. And I also want to say this, that we also have an issue with respects to the nature of people who are using drugs and alcohol. You take a look at the 25,000 people that were seen, or services were paid for by CBH over the last year. You're talking about over 86% had a co-occurring disorder, diagnosis. So we're talking about the fact that we need to now be much more behavioral in our approach in terms of looking at the entire population and what the needs of those populations are. Also because of looking at the social determinants of health and beginning to take a look at the fact that we have communities where people are under an inordinate amount of stress on a daily basis, and we need to begin to engage them in some very different kinds of ways.
Okay. All right, I'll come back on my second round. Okay, well, I'll come back.
Thank you, Councilman.
I wasn't sure with that, if that head nod was I could keep going or I'll come back.
Okay.
All right.
Thank you for making it easy for me, Councilwoman. Councilwoman Reynolds Brown.
Thank you. Good morning.
Good morning.
I want to continue on the opioid discussion, and I want to try to get as many questions as I can, so I'm okay if you exercise brevity.
Thank you.
Okay. You mentioned in your testimony that employees and providers are equipped to respond through training. So provide just in brief detail what that training looks like.
As far as overdose rescue training.
In dealing with cases that involve opioid overdose.
We've engaged Prevention Point to provide a series of overdose rescue classes. And those overdose rescue classes are 2 hours. Believe it or not, you can go online and get overdose training in about 20 minutes.
Wow.
But the reality is that what we want to do is make sure that people have a real gut understanding about overdose rescue. Also, where necessary, like for instance with recovery houses and with other entities, we've also been able to provide the actual Narcan or naloxone kits. So that people not only just get the training, they also are able to get the kits. Now, if they are able to do so through their Medicaid, then we assist them in terms of how to get the kits through their Medicaid.
Is that open to other employees in city government?
Well, we have reached out and
Beyond
we have
the
made
department.
it. We have reached out and we have made it available. The craziness is that we've taken it as far as our funding has allowed us to take it. We're looking to try to expand it. So yes, we are looking to see if we can't offer it to a wider, a group of people in city government. And especially, I would like to see us be able to offer to our recreation folks.
Yes.
Because, in many cases, you got people who are in the community who are using and who are overdosing and maybe even, on those grounds. So.
I would encourage you to have that conversation with the Mike DeBerdinas. What is the nature of your relationship with the police department, formally or informally?
Well, formally, we have facilitated over $200,000 to the police department for Narcan kits for the police. We also are involved with the police in terms of crisis intervention training. The Department of Behavioral Health has for several years now been working with police districts and trained thousands of police officers in terms of overdose rescue, in terms of crisis intervention training.
Okay, switch gears, and that my follow-up question is around MBE, WBE in participation and engagement. An alarming discovery for me was that the police department was having trouble finding a psychologist of color. So their MBE, WBE numbers on the professional services side was down. And my question to them was, do you engage at all with the National Association of Black Psychologists, Philadelphia chapter? So with that back text, is there any relationship in working with the police department to help them find psychologists of color or staffers who can provide those kind of services for that department?
Not as of yet. We have not had those discussions with the police department in terms of finding a professional staff. I'm assuming that you're asking professional staff that would provide services for the police that are African American, persuasion, as well as Asian, as well as Latino. Yes,
precisely.
We have not had those discussions, but we would be perfectly happy to sit down with them and make them aware of the network of providers that we do have with respects to the Department of Behavioral Health.
Okay. I'll work with the president to make sure that follow-through happens. On your MBE, WBE participation, from FY12 to FY17, your numbers moved from 13% to 17%. However, your goal for FY10 is 10%. So help me understand why that goal is 7 percentage points lower when you've exceeded it exceptionally well from FY12 to FY17. Why a lower goal?
Well, the goal initially was because for many of our nonprofits, there is a tendency not to necessarily declare themselves in terms of being minority-owned and whatnot. And I think part of it has to do with what they perceive as being a difficult procedure to go through.
What's the difficult procedure to go through?
Well, I think that the providers have said to us that it's been difficult for them.
What's been difficult? Achieving
As far
the goals?
as far as getting the certification is concerned.
So achieving the MBE, WBE certification?
Well, the goals themselves, I think that we are going to have to work with our providers more in terms of getting them to register in terms of certification around the MD goals. So.
Well, I would submit that if they want to receive city dollars, that they need to figure it out. It's taxpayers' money, and it's an expectation of members of this council that if you're getting a penny from city government, then you need to be compliant when it comes to equity and distribution of dollars across sectors around MBE, WBE participation. So we'll need to do a follow-up on that as well.
Okay.
Thank you, Mr. Chairman.
Thank you, Councilwoman. Councilman Dom, please.
Mr. Chairman, and still good morning. A few more questions for you. By the way, I love Councilwoman Reynolds Brown's comments about brevity. I love brevity. That's great. I want to go to your testimony on page 7. I want to make sure I understand, because in the big picture here, the increases are clearly coming out of, I guess, Code 254, right? Mental health and intellectual disability services. In 2016, it was $882 million, and 2 years later, it's going to be $1.294. That's a huge increase. So, trying to understand that increase, you have in your testimony on page 7, the second bullet point, it says a year-over-year increase was $117 million. How many people were enrolled in those services last year, and how many new people are enrolled with this increase?
We may have to get that to you, Councilman, as far as the enrollment is concerned. We saw an increase.
Look at your statement says this increase is attributed primarily to an annualized enrollment increase due to managed care expansion.
Oh, is this Health Choices or?
Yes, looks like it's Health Choices. Yeah.
On the Health Choices front, we actually increased our enrollment through calendar year 15. It was gradual. We also increased it slightly in 16.
So here's
and
what
it
I
was
like.
at 160,000 new members
In what year?
in 1 year. In 2016, 160,000 new members. So total enrollment was around 660,000. The way they calculate our financial member month capitation is really a different methodology. So it's 600,000 member months, but it's about 660,000 members in Philadelphia on medical assistance.
So you're saying in the last 2 years, we increased 160,000?
Correct?
Okay. And so I want to go back to what, I guess, originally Councilman Jones and Councilman Green and Councilwoman Sanchez talked about, and that is this financial piece. You know, in the private sector, we always say you're most productive when you're focused on dollar productive activities, categorizing the biggest dollar numbers first and working your way down. And from
So
the city's perspective,
Sure.
your department
Sure.
is the biggest, 1.6 billion.
So I can talk to the Health Choices component, which is the biggest component.
Well, let me tell you where I'm going with that.
Sure.
I don't know enough about your area
Sure,
for me
but
to make
I can give you-
analyze this
Sure.
information, but that's why I'm strongly recommending
Sure.
this outside audit, and as Councilwoman Sanchez said, to the Board of Directors of the city,
Mm-hmm.
for $1.6 billion, we need to know how this money is being spent,
Sure.
and not in a negative way, in a positive way. How do we make it more effective? How do we make our programs better? And by the way,
Sure.
all of you in that department should say, I look forward to that report, because that helps us do our jobs
Sure.
better.
So I would only like to point out, sir, on the Health Choices program, that there are state and federal rules around how it is the program needs to operate, and we would be more than happy to both share all of the financial accountability and audits we do, and if there is some external additional step we need to take for City Council, be glad to do that. We were created for the City of Philadelphia by the City of Philadelphia. CBH as an entity, as a 501c3, keeps no assets at all. We have the lowest administrative costs in the country relative to a managed care organization, and all of our resources, if there are savings anywhere in the system, really are returned to Philadelphia for behavioral health services.
Time out. I'm not asking you to defend
No,
what you're doing, okay?
but I wanted to make
What
sure
I'm
I
saying
was
to
clear
you is,
about what we are.
as a Board of Directors, as we are, we have $1.6 billion.
Right.
We need to make sure that that taxpayer money is spent efficiently.
Correct.
And for the best services, and we need.
Absolutely.
I don't think I'm capable of analyzing it. I think we need an outside company or consultant firm to do that. You said you had a report from Deloitte?
It's Mitchell Titus.
It's what?
Mitchell Titus is our auditors, and there's an audit on an annual basis that is external. It's required by the state, and it is submitted to the state.
But just an audit is different than a report done by a consultant analyzing the programs and determining the best way to invest the money.
So we also had an audit, which was our 3-year triennial by Mercer, which is also a national organization that came in to do a review of our program.
So just to wrap it up, you're going to make that information available to our
Certainly.
council president. Thank you.
Correct.
Thank you very much for your testimony. Thank you, Mr. Chairman.
Thank you, Councilman. Councilwoman Sanchez, please.
Thank you. Just to follow up a little bit around that, I think that after 20 years, I think it's only fair for us to ask for a programmatic detailed review of your structure. And I can understand why folks want to defend their current systems, but I will say to you that, I've heard the mayor, myself, providers, all speak to the current expansion of kind of the funding sources, and no one really looking at on a more thorough basis how we fund some of these services. And I think this is an adequate time in the history of the organization for us to do that. And it's something that we're going to continue to insist on, because as I talk to providers, and I want to get to the issue of provider oversight quickly, clearly, there are efficiencies in every system, and we don't want to do this without their input. But in light of some of the challenges that we have, I think this is the right time to begin to look at that. And so, from your board of directors, I know you guys reconstituted your board, and there's a lot of participation. I think having a public discussion about your board composition and their ability and time to really go through this stuff should be a public conversation, right? And I think my frustration is a frustration based on some of the challenges that I have on the ground. I don't doubt for a minute people's commitments. People like Roland have been in this business a long time. It is painstaking work. And, everybody that's in this business, I get it. I visit my providers, I visit school-based providers. No one's doubting that. But it is a big number, and I think we need to be able to create a forum by which people know. The irony of something being called healthy choices and people not having choices is a problem. And I've requested some of the information because I do want to have hearings where we begin to look at provider profiles. People should know that they're going to a for-profit provider what the composition and their management team is. They should know when they're going to a nonprofit provider what their composition is, and then more importantly, have a rating system for it. And, I would submit to you that state has failed us in that regard. And we've seen it in cases, and I'll let the appropriate council people talk specifically to those cases, but if the state is inadequate in their oversight, then we have a responsibility to step up in a more proactive way. And I know you're not resistant to that. I'm just saying it's going to happen. And so this is going to be a long conversation. I wanted to go back to Roland's conversation around opioid. And I know the opioid task force is putting some stuff forward. How is the city working with the new prescription database to inform potential doctors subsidized or reimbursed with us who have been either charged or are potentially could be pill doctors? How are we working with that state database?
Well, the PMP, as far as the state is concerned, is not necessarily open to us as far as the city is concerned. We have been working with the city with respects to notification that from the city that there is a pill mill, so to speak, that's going on. We have been a part of the original plan, the 311 plan that was put forward some time ago, and have been available to work towards that end, but we have not necessarily had an access into the state's PMP or the prescription monitoring program.
So what are we investing in terms of our own oversight, since we know not only do we have pill doctors, but we have pharmacies that are complicit? What exactly are we doing, 1, 2, 3, to monitor that?
Well, we are not necessarily monitoring doctors that are practicing in bad behavior, as much as we have notified the DEA of our concerns, as well as participated with making our providers aware that there have been issues as far as prescribing is concerned when we've been aware of it.
My time is up. When we come back, in case you need to get this information, I really want to speak to how much money we are investing in opioid treatment, how much are we investing in prevention, and then for all of, we talk about Prevention Point, and you know how I feel about Prevention Point, how much are we really investing in Prevention Point given the scale of the problem? Thank you, Mr. Chairman.
Okay. Thank you, Councilwoman. Councilman O?
Thank you very much, Mr. Chairman. Good afternoon.
Afternoon.
It's really just one topic, and I know that the mayor's task force combating heroin opioid made its press announcement yesterday, the final report, and those type of things, which is good work. And my question is, and I appreciate your attendance at the the regional meeting that we had. We plan to continue those, but it was a surprise to me to learn that all our surrounding counties, Chester, Montgomery, Bucks, Delaware, and Camden County have permanent task force to address the heroin opioid epidemic. Is there a plan or an effort to put together a Philadelphia task force to interface with our surrounding counties to address things like insurance and sharing resources and addressing in a more uniform way, more intelligent way, the big problem that we have with this growing heroin opioid problem?
Well, first of all, Councilman, thank you very much for your support and the efforts that you've made and your participation on the task force itself. I thought your regional meeting was the beginning of that. We have, and before the mayor's task force, there was a functioning opiate overdose task force in Philadelphia. We've been looking to, at each step, to combine, align, coordinate, in some ways, and integrate these task force efforts so that we don't necessarily, have a number of different entities that are doing the same thing, so to speak. We have been engaged with the other counties vis-a-vis the single county authorities in Pennsylvania. We had not so much with New Jersey, and you were in your regional meeting able to bring New Jersey over to the discussion. We have been, meeting ongoing with the mayor's executive commission for drug and alcohol, and having meetings in the community around that, over the years. And we have the Office of Addiction Service Advisory Board that has been also a part of this. So what we want to do now is begin to think in terms of how do we take all these different efforts now and begin to work towards using some synergy to bring to all of the efforts that we have in the city. And I think eventually we will have a single entity, whether it's your regional meeting or whether it is another group that is going to be on two levels. One, to work with us around the idea of holding our feet to the fire with respect to the recommendations of the Mayor's Commission, and then two, to look at how we can begin to address some of the low-hanging fruit that we have in the city.
Thank you very much.
Thank you, Councilman. Councilwoman Gimm?
Thank you very much. So I'm focused in on the $78 million that's spent on school-based services because I think it's really important, and especially because as we see a broader Medicaid expansion, I'm interested in how we can both use that opportunity to see improvement within our schools, but also see a broadening of services that go towards our schools, because I don't think there's any question about the need. And I'm interested in whether the number of schools served is about 100 schools that you're in. How has that number changed over the last 5 years or so?
So it has not changed significantly. The schools the 100 that are on the behavioral health side where the treatment services are, have been predominantly elementary and middle. There have been some changes when there's been a conversion, for example, to a charter, or there's been a closure. We then will move to another school. In recent years, we have really looked to the school district to help us to identify what are some of our higher risk schools that they would like us to move forward with. So, for example, we piloted the what was called the CAST program, which was a new school-based strategy that was in 5 additional schools that we, with the district, identified to try to think about could we actually employ a different model. And so it hasn't changed as much over time as we probably would like. I think part of the challenge is that folks would like it to just grow as opposed to really relook at what the need is. We estimate that 3 to 5% of any particular building would need treatment services, but that really relies heavily on the fact that we need the underlying, activities to be there. So we need climate, and we certainly need Tier 2, where we have some student assistance capability.
Yeah. I mean, I appreciate that, and I think it is important to note that the number of schools hasn't changed significantly, even though I think that the clarity about the need has been articulated very clearly across so many schools. And I think when we met, I shared with you a number of the top high schools that serve large populations of ELL students, special needs, or system-involved youth. And in particular, again, I want it to be understood that I think both CBH, DBH can, waiting for the perfect climate system to show up is actually not going to happen. What we need from from that 78 million that we're looking at in our schools is to actually create those climate environments. And so is there a chance that your department can both re-look at some of the programs that you're doing, but also expand? And clearly, in particular, I'm interested in expansion into the high schools where we have such high need, and climate is such a serious issue, and trauma in particular has much graver consequences than maybe we can even see in elementary school.
So I think it's a great point. We are always relooking at what the school services really net us. We are really thinking about the pilot projects that we're doing in the high school level, trying to assess whether or not they really are moving in the right direction. And some of them really have gone down and trying to do climate as well as treatment intervention, all really grounded in trauma resources. So yes, we are really constantly looking at where we can move forward. I would say that some of the costs associated with that are something that we do have to take into consideration about how to do it in a way that is the most effective, that we really target the schools that are the most challenged, that we can really do some strong intervention. We have lots of lessons learned from the pilots that we did that I think, we can certainly have some additional conversations about.
All right, thank you very much. I had more, but I will wait for my third round.
Okay, thank you, Councilwoman. Councilwoman Bass.
Thank you. So I wanted to go back to the opioid epidemic. And so one of the concerns that we have heard and has even been discussed here on the council floor from various parties is that, addiction is not new.
No, it's not.
And opioid addiction is newer to some degree, but even, the heroin epidemic is not new. But that the attention that has been brought on it is because the victim of addiction is what has changed. And so there's been a lot of conversation about when it was more of a black and a brown problem, that there was not adequate, funding, attention, resources, interest in the issue. And that when it became a problem for other communities, suburban communities, that's when it became more of an, we have to do something about that. And so I was wondering if you could, discuss that in some detail in terms of how we're approaching this epidemic and how we've approached these matters in the past. And one of the things that comes to my mind, and I'm sort of lumping two subjects together here, we do a lot of work on stop and goes in my district. And I see Commissioner Farley's here from the Health Department. We went out with the Commissioner and a number of other folks, the L&I Commissioner and Liquor Control Board, and we went to a number of different stop and goes in my district, in the 8th District. And incidentally, I have more stop and goes than I have public schools, just a note. But we went to all of these various stop and goes, and they are a function of alcoholism, another form of addiction. Mm-hmm. And so, this is something that's been going on for a very long time. And, when people see that we're not giving attention to those sorts of epidemics, and yet we, that have devastating effects, usually on communities of color, And then we have the opioid addiction, which is sort of, is obviously devastating. But, people feel that it's been made a priority over other forms of addiction. Can you talk about that a little bit?
Well, let me just begin by saying that the addiction system is a stigma-driven system. And in fact, I would dare say that behavioral health is stigma-driven when you consider the fact that people don't look, that it's really about a diagnosis, it's about a behavior, it's about a drug, it's not about people. And I've been saying over and over again for years that we need to stop chasing drugs and start chasing people. The reality is that we as long as it was a quote unquote inner city thing, people often marginalize the folks that were dying as far as drug and alcohol use was concerned. In 2006, when we had the first fentanyl epidemic, the topic in the city then was the increasing number of gun violence deaths, and reaching 400. Well, that same year, over 1,149 people died with the presence of drugs that year. And so, but it wasn't, I guess you can say, attractive enough for people to pay attention to it. So we have done ourselves a disservice, and I'm hoping that we don't do the same disservice now. That addiction and overdose doesn't really matter about color. I think the message that we need to be clear about is this, is that people are dying who are wealthy, who are white, who are male, who are black, who are female, who are Asian, who are Latino. The idea is that we need to begin to be clear about the fact of looking at the conditions in which people are living and beginning to address those conditions to begin to actually intervene before we have conditions that are producing the kind of reliance and the kind of use of drugs that we're seeing. Right now, the average number of drugs that we're seeing in our decedents, I think, is approaching above 5. And so it's not just about opioids. We're looking at benzodiazepine. We're looking at just 5 years ago, cocaine was the primary, culprit as far as overdose deaths were concerned. Alcohol in combination with drugs has really been a not so silent killer. So I would tell you that I agree very much with you that we do need to begin to think, expansively about the fact that it's not about the particular drug. It's about the fact that we have people that are suffering out here, and we need to get them a greater number of supports for their own well-being than we have right now.
And people are self-medicating. Yes. That's what this is. People are trying to medicate themselves with, whether it's an opioid addiction or whether it's alcoholism. But I agree with you, we have done a huge disservice by sort of categorizing this group is getting more attention, that group is not worthy of attention. But that has been what has happened, that has been the history. And, just thinking about one of my colleagues who said, Councilman Kenyatta Johnson, who talked about, people have been getting high in his neighborhood since he was a little kid. Mine too, As someone who's from North Philadelphia, I've seen drug addiction all of my life. So it's nothing that's new, but in some areas, it's very new. This addiction, the cycle, what's happening, and communities don't know how to deal with it. But again, when I have the businesses that I consider to be predatory that, really push alcohol. When you go into a lot of stop and goes, they say, oh, we sell cheesesteaks, hamburgers, hot dogs, fish, seafood, whatever. But when you go inside, there's no food sold or a very limited selection of food sold. Over 90% of these businesses in my district sold no food. Were supposed to be restaurants, are not set up to be restaurants, and clearly are just selling alcohol and snacks. Well, if you want to count potato chips and pretzels. But they are really just selling alcohol and shots of hard liquor. And so, that's something, when we look at the proliferation of liquor and alcohol in our districts, when you look at bars, beer distributors, stop and goes, all of these combine to offer such a level of alcohol and really prey on those who have a dependency that I would really like to see it to be more of a part of our agenda, because that is the unspoken addiction issue that's happening in our neighborhoods that we're really not dealing with. And it's, it's legal. These businesses are legal. We've checked them all out. They meet the requirements. They fit the standards. They do what it is that, legally they're supposed to do. But there's something very wrong here that I can walk into one of these businesses if I'm an alcoholic and I can buy myself a shot of hard liquor. And I have a 7-year-old. I can bring my 7-year-old in with me, and she can buy a bag of potato chips at the same time. There's something really wrong with how we're doing business and how we're looking at this problem. But I thank you for the work that you have done and look forward to further conversation.
Thank you.
Thank you.
Thank you, Councilwoman. Councilman Green.
Thank you, Mr. Chair. I wanted to follow up on some of the questions that Councilwoman Brown were asking regarding providers of color and providers within the City of Philadelphia. And I just want to clarify some of the questions that you, Mr. Lamb, those providers, or Class 200 providers, those are providers going through your organization, Department of Behavioral Health and Intellectual Services, correct?
Yes.
So I guess my question is focusing on Ms. Ernie and CBH. I know Mr. Lamb's office has provided me some information regarding the regular leadership meetings that his organization has with the Alliance of Community Service Providers and representatives of various minority nonprofit providers. However, my question is, from a CBH perspective, can you provide a breakdown of the providers of color that you engage with to provide services under Health Choices?
Yes.
Okay. And based on that breakdown, are you aware of the percentages or the ranges of those organizations in reference to their leadership?
I can. We did a calculation that looked at our total funds spent, which was close to $40 million. It was 37.7. One of the challenges, and I think this is what Dr. Lamb was trying to reference, is is that we don't really contract with many for-profit organizations. They are able to be certified. So we really do look at ownership and executive directors of for minority-owned businesses, both from the provider and the administrative payments. So it represented about 5% of total payments to providers and 2% of total payment to administrative vendors. And the majority of our provider payments are for not-for-profit providers. So again, it is an issue about, it is for-profit providers who can actually get certified. So it does create a bit of I think a misrepresentation about what we really try to accomplish.
Yeah, that's an issue that I've been concerned about for some time, ever since then the Minority Business Enterprise Council got out of the certification process of nonprofit organizations. That has left a big hole in the work that people have undertaken over the years to try to make sure that we are diversifying our providers, especially providers of color, considering the large amount of dollars that come through the Department of Behavioral Health and Intellectual Disabilities Services and CBH. The fact that we don't have an entity within the City of Philadelphia that can provide any type of oversight for nonprofit providers has been an issue and concern for a number of years. I know for myself and other current and also former members of this body, and that's something that we need to take up with the Office of Economic Opportunity to make sure they have the additional resources to do that. Also wanted to ask some questions regarding the work that your office has done regarding autism, and considering that I've been an advocate in that community for some time, and the office has been proactive. My question and concerns deal with the fact that how are we taking steps to provide additional services from a citywide perspective, considering that when my son was diagnosed with autism, which was 2003, that was 1 out of every 205 children were diagnosed with autism. Now we're 1 out of every 68. And so those young people will be teens, and from teens to young adults, and so we'll have a growing and growing population in not only the Commonwealth, but also here in the City of Philadelphia, considering we are the city of a first class. So what are we doing on a citywide level to prepare for that future when we have a larger and larger percentage of the citizens in this city who are on the autism spectrum?
So I'll answer on our behalf. I think one is that, certainly thank you for all your advocacy around the issues. We are really working through the Philadelphia Autism Project to bring all of those entities that are really currently providing autism services to the table. So everything from the 0 to 5 on up. So we do have a early intervention and school and initiatives so that we have a common practice around autism, which is one step. I think as young adults and our youth grow up, thinking about young adult peers and thinking about how it is we support individuals, well, autism will be another and is another priority coming out of that, our Philadelphia Autism Work With You. On the adult side, the state is making some changes around how autism is going to be supported and have really currently put forward an idea that it would be supported through a waiver that has historically been for individuals with intellectual disabilities. I think that is yet to be seen and work that we really should think about how it is that we interface with that. And at this point, I don't know that we know.
Well, in that regard to the waiver, I know there's some proposed changes on the waiver from autism only to, I believe, a broader spectrum under IDS. And that's raised a number of concerns and questions in the community, especially considering the waiting list for that waiver is substantially long, and it continues to get longer when you look at the population increase. So that's something that we hopefully continue to work on. I do have some additional questions, which I'll come back in the next round.
Thank you, Councilman. Excuse me, Councilwoman Reynolds Brown.
Let me thank you for your very eloquent statement of fact as it relates to the opioid epidemic and why there has been such a different level of seriousness about that issue in years past. Your vision of the future is quite encouraging as to how we should deal with it. I appreciate that.
Thank you.
One of you stated in your response to Councilwoman Gim that there are about 100 schools. You're in 100 elementary and middle schools. Is that correct?
There are what are called school-based treatment services in 100 elementary and middle schools. Buildings in the school district.
And who makes the request for those services?
Those are services that really are from first an evaluator who really evaluates the child to determine what they need. Mm-hmm. And then those referrals really come to us for authorization. And sometimes they can come from a teacher, they can come from a parent. So many people can really refer that child for the evaluation, and then the evaluation is what triggers the opportunity for the services. The services are on site at the school, so they actually have clinicians who are in the building.
I see. Okay, I'll speak with you offline about a school in South Philadelphia which has 4 boys, all under 12, who terrorized the school.
Okay.
And
would be glad to follow up.
yes.
Okay.
Okay. And that's from multiple teachers and educators from that school.
Okay.
What are the procedures in place for staffers to follow up with patients 30 days after discharge? Your testimony reflects that there's a 60% target rate after patients have been discharged. How does one arrive at that number? What drives that number?
So that's probably Health Choices data that really we're required to report on that through the state. And there are a couple of things. One is where we find success is that if we combine targeted case management from the community with the hospital system, and we've actually created a performance incentive for both sides to really come together, and where we see success in that improving is when in fact we have a strong discharge plan from the hospital, and we have a connection to a community-based system and targeted case management who has a relationship with me as the patient can get me to that appointment. that's where we have our highest success and the opportunity for a follow-up, which reduces the need for any kind of readmission rate. So it's
Okay.
really connection to community services, which makes a difference.
Okay. To underscore the questions that have been raised by Councilman Green and I, for your FYI, DHS provided, in my personal opinion, an exceptional grid that provides a schematic statement of all of their MBE, WBE activity. It's a one-pager where you get to see flat out who's who and what's what. I'm going to share that with you, and
Okay.
I want you to pass to the chair within the next 30 days a similar delineation of what CBH is doing in those areas.
Be glad to.
And so what is the nature of the interface with OEO today as we sit here?
So I'm sorry, do you want that, is that directed to me or to the?
Whoever
Oh, go
is
ahead.
appropriate to answer.
We, as far as our contracting is concerned, all that goes through OEO.
Okay.
So we don't have anything that I understand, and maybe nothing that we understand that doesn't go through OEO.
Okay. And so has the concern been raised with them that you have nonprofit providers that are struggling with meeting goals, meeting numbers?
I need to, excuse me one second.
Sure.
Please identify yourself and proceed.
James Huffler, Chief Financial Officer and also OEO Officer.
Okay. So you live and breathe this issue every day?
Yes. So our department,
Pull the mic closer, please, sir.
mostly contracts with non-for-profits, which cannot be certified. As you look at our numbers, our for-profits only are $14 million of our total budget.
Only is a big number when you're
Well-
getting anything from the city.
Out of that 14 million, that is what we can certify.
Okay.
Only those agencies can be certified. Within that 14 million, we do have some early intervention providers that we know are minority or women disabled. They say it's not in their best business interest to be certified. We've worked with OEO, we've worked with our department, with the agencies. It's not, they have the business they need. They say it's not on us to be certified.
Do they articulate why it is not in their best interest?
They have all the business they can use, so they do not want to be certified.
And you said these were the nonprofits?
No,
Or these were the for-profits? that-
only the for-profits can be
Can be
certified,
certified.
yes.
So if you have for-profits that choose not to be certified, should we continue to do business with them,
Yes.
with city dollars?
I believe yes, because they are minority women. We know, they come in to sign the contracts.
Okay.
To not do business with them because they won't, they do not feel it's in their best business model to be
Okay.
certified. And again, it's a small portion of our total contracts.
But if it meets the needs of the department and it serves them in a way that's useful to the department,
We have worked with all and every time we do an RFP or a go way out and are doing a for-profit, we do work with OEO. We do try to get as much as we can in as minority, women, disabled contractors. But again, it's very small part of our business.
Okay.
If you look at our non-for-profit organizations, and if we could get those certified, we would take it through the roof.
so maybe that's a challenge for city council to legislatively figure that out.
We do look at executive management, we do look at the boards, we do look at the staff of all our agencies. And for example, we are over 90% staff-wise minority, female, or disabled in
And
our
so I
system.
would drive the drill down further and say, of that 90%, what percent are in positions of leadership and responsibility?
We also have that information.
So that's what I want to see on a grid.
We have all that information, yes.
Okay, not tables, but on I'll provide you the DHS model, which I think is,
I do believe we're using the same model.
okay, I'll look forward to that schematic feedback. Thank you. Thank you, Mr.
Thank you,
Chairman.
Councilman. Just want to remind the committee, we're an hour and a half behind, and we have 4 more departments to come, so. Councilman Sanchez.
Is that your way of saying wrap it up?
trying to be subtle here.
You're not being subtle. Let me just encourage, with nonprofits who don't get certified, being proactive and asking people to self-report on that is more than appropriate and should be considered a matrix that should be included in provider profiles. Having boards of directors and compositions and leadership teams is a norm now and our ability. There's nothing that prohibits our organizations and departments for asking that. Just wanted to quickly go back to the point Councilman O, and Roland, you were at a meeting. I'm a little concerned about the vagueness in the response about our willingness to put forth, this task force. And you talked that there was an internal Philly task force. This internal task force, one of the things that I was the most impressed about from Montgomery County and other counties is that they had all their top level officials who were really triaging some of these issues. And what was for me most telling at that meeting was their openness in saying that they had available beds. And in light of the fact that we're talking about, and the 7th is ground zero for some of this stuff, in light of the fact that we know that most of the folks in Kensington are from the counties, don't you think this would be an urgent matter for us to figure out how we can quickly get people to treatment in their counties so that we're not assuming their cost?
Well, we were looking at, and again, we estimate there are about 11% of the folks last year that died from overdoses came from outside the county. As far as the total number of people who are coming from out of county, we're looking at approximately, I think, a 15% estimate. As far as the state is concerned, all one has to do is have an intention.
How do you get that data, 15%? I mean, when I go to Kensington, I see 60% of the people walking the streets not proper to Kensington. How do we only end up with 15%? Not from Philadelphia, not from the area. Suburban, white kids.
Well, again, we're looking at the numbers from street outreach teams in terms of shelters, and overdose deaths. We're seeing, that's how we're estimating. As far as the number of people coming from not from Kensington, that may be the case, and in fact, it probably is the case that you have a good number of people that are coming from other areas of the city. But the reality is that a number of those folks that we're estimating is about that 15% level.
Yeah, that seems very low from the optics, from the daily optics that I see over there. So going back to my question in terms of how much are we investing in treatment, how much are we investing in prevention, and how much do we give prevention point given the scale of what they're doing on the ground there?
Well, we're investing about $93 million overall as far as drug and alcohol treatment is concerned. Prevention is a number that we have to take a look at as far as the overall number for prevention is concerned. I think it's about $4,155,000. Prevention point, we're putting about $730,000 or about $731,000 into prevention point this last fiscal year.
So the $4 million in prevention, obviously I'm going to ask you for what makes up the $93 million, because that includes everything. How do we monitor the utilization, and this is an important coordination piece as it relates to judge sentencing and putting people in beds? Of our beds, how do we prioritize our beds to ensure that they're going to the highest need patients?
Well, first of all, we looked at medical necessity criteria. And out of that medical necessity criteria, when a person is assessed appropriately and needs to be in a residential treatment facility or in a hospital bed, that's what is approved. When you have people who are assessed as needing something less, they are approved for that. But it's part of the assessment process that everyone should be going through.
How about for the court referred ones who are required for treatment? Do they go through an assessment piece too?
Yes, they have to go through an assessment process as well.
So if a judge says you got to go into treatment, who determines what treatment? Or is the judge, the judge mandate?
If you take a look at, for instance, the Forensic Intensive Recovery Program, which works with the courts, an assessment is done, recommendations are made to the courts, or recommendations are made after the court's decision to adjudicate someone into treatment. And remember, treatment involves 4 levels of care, more than 9 service types for folks. So that means that you can go anywhere from acute inpatient stays all the way down to outpatient.
Okay. I have one more question, and if you want me to answer it now, if not, I'm going to go back around in the rounds. Huh?
If you have one more question, just finish. There's 2 other people, but that's okay. Go ahead,
Okay.
finish.
Real quickly, one of my biggest frustrations has been around, I think what Dr. Evans used to call the saturation of services in my community. We have had 4 providers with federal intervention, and the treatments have been closed. In light of those things, what are the protocols, if any, about when we decide to terminate a contract with a provider, and I understand innocent until proven guilty, when there is federal intervention for potential fraud?
Well, in many cases, the federal intervention is not something that we are readily made aware of. When we are made aware of it, our antennas go up. We begin to scrutinize what that intervention is. We also are looking at the fact that if you have a provider that's in a community where people are going to that provider for services in that community, that we don't want to necessarily, have a knee-jerk reaction before that provider, is determined to be, out of step. When we take a look at a provider from our perspective, we're looking at the quality of care, the consistency of care, and the satisfaction that goes to the provider community. It goes to the people who are using the service.
In that assessment, when we look at how do we monitor the volume? So I had a provider who no longer has a contract with you who said to me he has 115,000 visits a year, right? And then when you work backwards of that, it's like, okay, that's like literally 15 minutes, assuming he worked 368 days out of the year, going backwards. Who monitors stuff like that to determine volumes, and what is the protocol?
Well, I think that I'll let Joan answer, but I think the reality is that there is monitoring that's done from the point in time when an authorization is made into a program. And remember, for an outpatient provider, that authorization is not necessarily prior to the admission. That's usually the authorization comes once a person is admitted to the program. So you usually have a retrospective relationship with an outpatient provider. Joan, you want to?
Yeah, I only wanted to suggest, we have a compliance department, so they actually look for outliers related to those kinds of things. So you can look in our claims data and see you have a provider who is billing, there's a billing anomaly. There's something that looks different or distinct from someone else. We will actually go in, we will pull the charts, we actually do a review, we have staff that go on site. So that's one component. We also have the program quality. So as a federal audit or a lawsuit comes in, that will prompt us to do an internal meeting across all of our systems to say, what do we know about that provider? It typically will do an on-site, so we will actually go in and do a review of that provider ourselves. We will then, sometimes we will close admissions, as we have, I think, from the organization you're speaking to. We can close admissions and really say to them, you must do a corrective action. You're not eligible for anything until we really see a corrective action. And then we go on and try to demonstrate, and they must show us that they've actually made the changes that they told us they would make. But we look for, on the compliance side, things like impossible days. So if you see that somebody is doing 14 hours of work, we would look at that to say, that seems like pretty rigorous, let's really confirm, and we would actually do an audit of the chart. They're intensive because you have to go in and look at the individual chart, you need to look at all the documentation, but that's what our compliance folks do. If we find an issue, we're required to report it to the Attorney General's office or to the Bureau of Program Integrity, which is a Medicaid office that sits within Pennsylvania DHS.
Okay. Again, relying on the state and their auditing is not necessarily an adequate situation for me. Thank you. Thank you, Mr. Chair.
Okay, thank you, Councilwoman. Councilman Green?
Thank you, Mr. Chair. I'll be very brief. I know we've previously spoken about the school district's pilot with ABA, and my understanding you are working with the school district in that regard. Question that I have is that there's current litigation regarding ABA services And I believe, from my understanding, is that based on the outcome of that litigation, there may be additional services coming to the city for ABA. Now, would that go through the school district, or would that be a state grant to the school district, or expand the state grant? Are you familiar with how that?
No, well, the litigation that I think you're referencing is actually Medicaid litigation against us, against the Department of Human Services. So there is ABA that we are required to offer. As a result of that, we created a standards document. We also just did an RFI, request for information, from our agencies to really bring them into the opportunity to learn more about ABA and to get certified. So we'll have expansion of ABA through our initiative. I believe there's also potentially a grant at the school district level, but I can check on that and confirm.
State grant that came to the school district, because I know initially the concern that people had was the school district really partnering with CBH on those services? My understanding, they are doing that. Thank you. Thank you, Mr.
Thank you.
Chair.
Thank you, Councilman. Councilman Dom.
Question for you, and I'm kind of asking this in conjunction with Councilwoman Sanchez, and that is, 2 years ago, after the primary, Mike Newell wrote an article in the Inquirer about an area of the city that doesn't vote, which was 3rd Indiana, the gurney problem. And Councilwoman Sanchez took me on the tour of the area just 2 years ago, and now we're sitting here 2 years later, and I'm just wondering, what involvement is your department? How many resources do you have applied to this, and has it started, and what's going on?
Well, you're talking about the Gurney Street area.
Yes.
We have poured tremendous amount of resources from the standpoint of making treatment more accessible, developing services at Kensington Hospital regarding their methadone maintenance program, putting mentors on the street to reach out to single language speaking population, enhancing the role that Prevention Point is playing as far as being able to outreach and engage people. And we've actually, reached out to treatment providers to provide more buprenorphine as well as other medication-assisted treatment services in that community.
So if I go up there this afternoon, am I still going to see 40, 50, 60 people living there?
Yes.
And what are we doing about that?
Well, as I understand it, there is going to be a sweep of the area at some point in time by law enforcement. We have been in conversation with them with respects to making sure that we have treatment services available for folks who are going to be needing treatment, and then also providing supportive services, to more or less engulf them so that we can keep them engaged in treatment. That's the biggest thing. That's our biggest concern at this point in time.
People ask me all the time, what's the difference between business and government? And if you were in the business, this wouldn't be 2 years or longer. Councilwoman Sanchez, probably 8 or 10 years. This is an embarrassment for the city that we let this continue. So whatever we can do to resolve this ASAP, we need to do. This shouldn't be going on like this. This is a disgrace.
Councilman Dom, I would agree with you wholeheartedly. I think that on some level, this is an issue that really requires all hands on deck. Behavioral health, the justice system, as well as the private contractors in terms of Conrail and the like. I think that we need to have a concerted effort that needs to be collaborative and needs to be, coordinated. So I agree wholeheartedly with you that this is.
But I've heard that now for 2 years. Okay, the collaboration, concerted effort. I've heard all that for 2 years. I'm just saying we need to set a goal and get this resolved in the next 30 days. It's an embarrassment. It's made national news. This is a black eye for us. We need to fix it.
I agree.
Okay, thank you. Thank you very much, Mr. Chairman.
Thank you, Councilman. If there are no other questions, sure. Councilman Sanchez.
Cheating. I want to go back a little bit to the school-based services and around some of the coordination. I think it's really important, particularly as we get ready for the school district hearings, because the school district does not control the selection of providers, and many times is unaware of the prevention and intervention strategies on a child-by-child basis. If there's a way that you can demonstrate to us on a school-by-school level what those investments are, because outside of your group processes, the fact is you may have children receiving some sort of services. I don't know how that data is collected, but I think that one of the challenges with the community schools is really getting a handle of what's already there. And before it could really weigh in about what are the intervention strategies that need to be changed, notwithstanding, the fact that many providers are selected with very little input from principals and parents,
So one thing just to follow up, as you heard me say earlier, there were a series of meetings with principals, so Dr. Evans, David Jones, Dr. Height, and others. One of the things we gave the principals is their information so that they would have who was the student assistance program, who's the prevention program, who's the treatment program, and we do that routinely. We actually have staff who are on the ground that give that information to every school about who is in their area. I would say for sharing of information, there are laws that aren't going to permit us to do that, but we really try to make sure that there's a coordinated effort with anything that we're funding in the building. So, as you point out, you want that really to be integrated.
Yeah, the mayor's been pretty vocal around, how those decisions get made and are better localized and leveraged at the principal level. People should know what's in their building, and they should be able to influence that, and it should be part of an IEP plan in a more thoughtful way. So sharing information is one, but ultimately, if I can't decide as a principal, this is from, the short period of time I substituted as a principal, if I can't decide the kind of intervention strategy based on my own psychologist, we're working at cross purposes. Thank you. Thank you, Mr. Chair.
Thank you, Councilwoman. Being no other questions, I know you want to spend the rest of the afternoon with us, but thank you. Thank you for everything you're doing there. Our next department is health. Are you okay? You sure? Okay. All right, next department is the health department.
I want to thank City Council for all its efforts and support of us.
Okay, thank you, sir.